Good evening. Thank you all so much for joining us. General practice has so much on its plate at the moment, and we know your time is precious, so I hope we'll use it really well tonight. We're going to spend just an hour thinking about the impact of the proposed NHS reforms on general practice. Now, we'll all remember the controversial Health and Social Care Act of 2012. The then NHS CEO, David Nicholson, said that the upheaval was so colossal it could be seen from space. But it pretty rapidly became clear that far from ending all reforms, that act created the need for more changes. And in fact, NHS leaders found themselves working around legislation which was inconvenient at best, obstructive at worst. So further NHS reform has been on the cards for some time. But it certainly feels to me, at least in my practice, that we're so busy doing the day job at the moment that it can be hard to engage with this sort of system level change. And it's even hard to know whether or not we need to engage with it. So what's it all about? Should we care? We've got a fantastic panel here this evening to help us discuss those questions and more, and I'm really grateful to them for giving up their time. Farzana Hussain has been a GP in East London for 18 years. She runs her own practice, and she's also a PCN clinical director. Until very recently, she was co-chair of the NHS Confederation's PCN network. Professor Martin Marshall won't be a stranger to you. He's also a GP in East London, and he's current chair of the Royal College of GPs, as well as being a professor of healthcare improvement at UCL. And really grateful to Rob Webster for giving up his evening this evening. He's lead CEO of West Yorkshire and Harrogate Health and Care Partnership, and he's responsible for leading that integrated care system and its 4,200 staff. I'll be chairing our discussion this evening. I'm Bex Fisher, and I spend part of my week as a GP and the other part as Senior Policy Fellow at the Health Foundation, where I lead our work on primary care. I'd really love to put your questions to the panel too, so please stick them in the Q&A function. If someone else has already asked the question you wanted to ask, please upvote it by clicking on the thumbs up icon. We'll try and answer the most popular questions as well as some that catch our attention. And for anyone who wants to tweet along tonight, we're on THF Primary Care. Now, before we dive into our panel discussion, I know we've got people joining us tonight from a wide range of backgrounds, and I don't want to assume any particular prior level of knowledge. So I'm just going to spend 5 minutes running you through a quick summary of what the proposed changes are. This is broad brushstrokes rather than minute details, but hopefully it'll get you up to speed on the context. Just give me a second to share my screen here. Brilliant. So the bill that we've got coming through Parliament this week, what started as a white paper in February this year. And broadly speaking, the Department of Health and Social Care set out changes in 4 buckets: working together to integrate care, reducing bureaucracy, enhancing public confidence and accountability, and then their catchily named additional proposals bucket. But broadly speaking, I'd suggest the bill's about 2 things really. It's about collaboration and centralisation. The first part of that, not so controversial. The second, really pretty controversial. And the title of the white paper is worth saying is a little misleading. It alludes to including social care, but actually the white paper itself was pretty much focused on the NHS, and the bill is too. So you might very reasonably say, why is this happening now in the midst of a pandemic? To unpick that, we've just got to look back at recent NHS history. And the NHS has kind of been waiting for this since 2012, in part to tidy up some of the mess that was made by the Health and Social Care Act. That act really tried to use competition to drive improvement in the NHS, and it did so by creating a really quite complicated web of organisational structures. Since then, NHS leaders have tried to work around that act to prioritise collaboration over competition. And collaboration has really been the flavour of the 2 major plans of the era, the 5-year forward view in 2014, and then the NHS long-term plan in 2019. To help join up services and overcome some of the fragmentation that the 2012 Act created, the NHS made partnership structures, first STPs in 2015-16, and those then evolved into integrated care systems. But the problem has been that those partnership structures don't really have any formal powers. They don't have a legal basis, and that can make working together quite difficult. So the basic idea of this new bill, from an NHS perspective at least, is to resolve some of the tensions between the formal rules that were created by the Health and Social Care Act in 2012 and some of the ways that the NHS has been working for a while now and wants to work in future.
Sorry, Bax, your slides aren't on. You're not sharing.
Oh, that's my apologies. Let me
There you
go back. Can we see slides now?
Yeah, all good.
Thank you, Nick. So what does the white paper actually say? Well, the first part of the white paper, now become the bill, was about increasing collaboration. The second part, much more controversial, is a politically driven set of changes. And then the third set of things that I'd like to highlight as well are things that a lot of people felt ought to be in the bill, but haven't actually made it in. So what about that first bucket? Well, the most important set of changes in the first part on collaboration and integration were to formally establish integrated care systems in NHS statute. NHS England defines integrated care systems as new partnerships between the organisations that meet health and social care needs across areas to coordinate services and to plan in a way that improves population health and reduces inequalities. In June, just a few weeks ago, an ICS design framework was published and it set out the core purposes of an ICS. Again, there were 4 of them. They were to improve outcomes in population health and healthcare, to tackle inequalities in outcomes, experience and access, to enhance productivity and value for money, and to help the NHS support broader social and economic development. The plan, in broad terms at least, is that there are going to be 2 parts to an integrated care system. The first part is integrated care boards. They're essentially going to be responsible for all NHS functions in an ICS area, and they're going to take on the duties currently held by CCGs. So the day that integrated care boards are formed, CCGs will be abolished. The second part of integrated care systems are so-called integrated care partnerships. They're slightly more nebulously intended to bring together the partners within a system, and they're meant to align ambitions, purpose, and strategies. It's worth knowing that the white paper that preceded the bill also focused on what it called the primacy of place, by which it means that services should be joined up at place level. They understand that to roughly mean local authority type boundaries. So you're going to have an ICS at system level, that's perhaps 1 to 3 million people. Below that place level, perhaps groups of 250 to 500,000 people. And below that, the smaller neighbourhood level where PCNs operate. This is the much more controversial part of the bill. The changes to national roles and powers, you might hear that referred to as powers of direction. One bit of that's not so controversial, merging NHS England and improvement. That's essentially been the case for the last couple of years in working terms at least. But the second part of this is a real kind of political centralisation of power back to Whitehall and a broad increase in the powers of the Secretary of State for Health. So if the bill is passed in its current form, the Secretary of State for Health would suddenly have the power to intervene at any point in local level service reorganisations, to transfer functions to and from arm's length bodies, and even to abolish an arm's length body. So that's a pretty significant change, and certainly a change of direction from the Health and Social Care Act, which pushed a lot of power out of Whitehall and over to the arm's length bodies. And finally, what wasn't in the bill that lots of folk, including me, thought perhaps should be in there? Well, there wasn't much on workforce. In particular, there was no long-term workforce strategy for the NHS and social care. There wasn't very much on public health, a little bit on things like water fluoridation, but certainly no cross-government strategy on health inequalities. And there was no significant fix for social care. What you might be asking about primary care. Well, if you Control F on the bill, you won't find many mentions of primary care or general practice, the same on the preceding white paper. But there was a bit more detail on what primary care will be expected to do in the ICS design framework. Each integrated care board is going to have 1 member draw from primary care medical service providers within the ICS area as a minimum. And there's an intention that primary care should be represented and involved in decision-making at all levels of the ICS. There was also confirmation that with CCGs going, funding for primary care is going to flow from NHS England to the Integrated Care Board, where commissioning of primary medical service is going to be held. Now, I'm going to stop talking now because I'm really keen to hear thoughts from our panel. Do please start dropping questions into the Q&A if you haven't already. And I'd like to start just by asking each of our panel members the same question, if I may. Martin, we'll start with you first. Unlike the 2012 Act, which really brought in CCGs, it centred GP-led commissioning, we've got another set of major NHS reforms here, but one with relatively little of a focus on general practice. So I just wanted to ask you how significant you think these reforms are for general practice and why.
Yeah, thanks, Beck. It's a key question, isn't it? So thank you for inviting me, first of all, and welcome to everybody. Thank you for joining this webinar. I've got mixed feelings about this particular policy initiative, I have to say. So on one side, I'm actually really quite excited. There's never been a more important time to address the fragmentation that was designed into the NHS in 1948 with our kind of hospital silo, our general practice silo, and our community silo. And actually, at a time of stress is a time when often the service is more receptive to change and more able to engage with change. So at that level, it's really exciting. It's also exciting because I've done quite a lot of research in the field of integrated care, and it's very clear from the international evidence that integrated care systems can deliver better outcomes at lower cost. And indeed, there's one particularly famous study that suggested you could deliver the same outcomes for 20% less cost. Now, it's contested research, but actually there's no doubt at all that there's a price to be paid from living in silos, from fragmentation. So at that level, I think it's really exciting, and it's very important that general practice engages with this. But I'm also skeptical, maybe even deeply skeptical, I think it's fair to say. In the last 20 years, I have seen at least 9 major policy initiatives to reduce fragmentation in the NHS. And you can be pretty sure if you have that many policy initiatives, it's because none of them are working very well. So the question is this going to work any better? And I think that's a really important question. I'm also skeptical because if general practice doesn't engage with this, it's not going to work. And the vast majority of GPs are in survival mode. They've got their head down. They can see the problems of fragmentation. They see it from a patient's perspective, but knowing what to do about it and knowing whether this particular policy initiative is going to make a difference, I think is really difficult to assess. And if I look across the conversations that I have at a national level with the 42, 43 ICSs that exist, I reckon probably somewhere between 10 and 15% of them are in a really exciting place. So they're already thinking about the potential of a more integrated, more patient-centered, more public health orientated health service. They're looking at the necessary redesigns to make that happen. They're already engaging general practice in what's happening. So that's really exciting in that 10 or 15%. There's also a small group of ICSs that see this as nothing more than just another set of NHS reforms, and it'll allow them just to do a bit more service reconfiguration of hospitals. The kind of stuff that they should have done 10 years ago or 20 years ago, but never quite got around to. And then the large part is just slightly confused about what this is all about, and almost certainly will wait for NHS England to tell them what to do. So we're going to carry on with the same kind of command and control mechanism. So actually it's a relatively small portion of the ICSs at the moment that are in a positive place. So I think there is a tension between excitement on one side and skepticism on the other. I think as a college, our responsibility is to try to enable success of this initiative. And so we're working really hard in a number of areas. The first area is we have called very strongly for a robust GP voice throughout all layers that you've described. It was our lobbying that managed to get a GP onto the board. We're not pretending for one second that's going to make a massive difference, but it's symbolic, and actually maybe it's important in terms of flow of funding. So that's great. But what we need is GP leadership throughout the whole system, and particularly where integration really happens, which is tough conversations between GPs and specialists and patients about care pathways. That's where it really happens. That's where you need GP leadership. So GP leadership is important. The second thing we're doing as a college is shining a light on good practice, and there is good practice out there, and our job is to demonstrate it and demonstrate how it's working. I think that's great. The third thing that we're doing is calling for support in organizational development. No other sector, no other business would think that you could completely change the culture and working practices of a group of people, all health professionals, and the way they interact with their patients without having adequate organizational development intervention. The NHS has been terrible at doing that, and that's why the NHS generally is so poor at change. So that's the third thing. And then the final thing I think you've referred to, we've alerted to the very significant warnings that this might look like sophisticated legislation, but if it doesn't address workforce, if it doesn't address social care, if it doesn't address inequalities, It's basically not addressing any of the wicked problems, enduring wicked problems that are out there because they're too tough, and that doesn't look like ambitious lawmaking to me. So I think, in summary, I'm really excited about the potential. I'm concerned about the realities of being able to deliver that on the ground. I think if we work really hard, we'll be able to make some progress, and that's what we as a college are trying to do.
Martin, that's enormously helpful. Thank you. There's loads in there. I'm going to bring Fazana in for her thoughts next. I can already see questions popping up. I think that representation, how a GP is going to be represented, primary care more broadly, is going to be a big theme through this webinar. Also, is this really going to benefit patients? Lots of people wanting to know that. Fazana, let's have your thoughts on whether this matters.
Well, thank you for having me, Rebecca, and thank you to everybody for joining us on your busy evening. So really echoing a lot of Martin's thoughts, I think this is important. And I think one of my reasons for saying that is because we can't go on as we are going on. I think the pandemic has just shown us how fragmented the system is. I think, I work in Newham in East London, running a list of 5,000. I've been here 20 years now, and we had the highest COVID death rates in the country. What I think is important is how this bill is going to affect the work on the ground. How is it going to make things better for my patients, for our communities? And so I think this bill is important because we do need a change. A bit depressed by listening to Martin about the number of changes that have happened over the last 20 years, and we're still here. But look, I'm new at this, so I'm going to stay optimistic. I think one of the issues for me is that as CCGs morph into big integrated care systems. So if we just take North East London as an example, in London we've got 5 ICSs. North East London covers 2 million people. And those 2 million people vary from a more affluent area, which is very green and has a lot of elderly Caucasian people, to an area where I work, where we're 74% BAME, we're young and we're dying. And one of the things that I think is going to be a challenge is how we actually bring services in for the relevant population. I think I'm distressed that there is very little detail about that, and about what you were referring to earlier, neighbourhood level or the primary care network level, 30 to 50,000. My own network is a bit larger, 67,000. And are we really going to move from that 1948 NHS of we're treating sickness to we want to do preventative care and do health and well-being? Because if we're going to do that, then the 4 bits that you spoke about and Martin repeated are not in there. If we don't look at public health, if we don't look at a workforce with the best will in the world, if we haven't got the people to do that, we're not going to achieve anything. Health inequalities currently is very much talked about, but actually what is health inequalities? From people dying of COVID because of poverty to people who are elderly and might not be able to get to services because of access, transport problems. There is quite a wide thing. And I do think we need to get to that level of detail, just as Martin said, because actually the real change is going to happen at that primary care network level, with GPs sitting with their communities, sitting with public health, sitting with our acute trust. Rob, for example, is going to blush now. It's no secret and no surprise to me that he was voted HSJ's CEO of the year, because he's got an integrated care system, and I've heard him speak, and he so gets it. And I think if we could clone Rob 42 times, we'd be fine. But actually, we can't clone Rob 42 times. And there are certain, ICSs who are saying, well, you've got representation of primary care, you've got the one person on your board, and you wonder, how will that one person bring about the views of so many diverse patients and so many diverse networks. So I think that we need PCNs to be involved with ICSs. I do think we probably need primary care networks to have a lot more power, perhaps have delegated power to make those decisions rather than just be part of the partnership. And I think we're not seeing that two-way conversation at the moment. At the moment, it is still very command and control, ICS down to PCN. And I'd like to see that a lot more horizontal.
Thanks, Fazana. Rob, how significant from your perspective as an ICS lead are these reforms for general practice?
Well, firstly, I sort of declare an interest because as an honorary fellow of the college, I'm a big fan of primary care, and it plays a fundamental role in our system. Fazana, if I was cloned 42 times, I think my wife couldn't cope. That's definitely true, and nor could I probably. I think I'd start really by bringing us back to the fact legislation doesn't change anything really. The implementation of our strategies and the changes in the way we deliver care will change things. And we've been doing this for 5 years now, just to remind everybody, STPs, integrated care systems, without the underpinning legislation have existed for 5 years. And we've been involved in the biggest workaround in history collectively. We've tried to make it work because, as Fazana says, health inequalities are real and shocking, and but not surprising to us. And what we should be doing is looking at how do we start to collaborate to address shocking inequalities, to address the shocking inequity that exists in our communities and in the places where we live and work. So in West Yorkshire and Harrogate, which is covers a population of 2.7 million and has, I guess, 52 neighbourhoods or primary care networks. It's got 5 places and 1 integrated care system, 1 acute collaborative, 1 mental health collaborative already. We see the legislation as really catching up with practice. And as part of the work we do, I think one of the things I want to reinforce is that the legislation being pretty high level and permissive is essential because different places will be different. And I don't want primary legislation defining what a neighbourhood model should look like, because it won't be right. Now, as a former senior civil servant who's drafted legislation, I know it'd just be wrong because we can't dictate from the centre how a neighbourhood model should work in Newham, in Chapeltown, in North Leeds, in North Kirklees, in Dewsbury. You know, we wouldn't get it right. So one of the things I would ask you all to do is, yes, be sceptical like Martin, but don't be cynical. And what we should be doing is asking the question all the time, is the implementation of the policy that we see in front of us going to address the inequalities that we see? Is it going to allow us to manage unwarranted variations in care? And is it going to allow us to use our resources wisely? And in doing that, we should all recognise we work in a system already. And calling it integrated care systems fine. Having a statutory organisation that's called that is a bit dubious, I think. But having a system where people work together, which has subsidiarity as its fundamental principle, is really important and countercultural. So we started this conversation as if the ICS body will be in charge. It will not be in charge. At its best, what it will do, it will facilitate working where people themselves do as much as possible. If they can't do it, they're supported at home to do it. If they can't do it in their home, they do it in their neighbourhood. If they can't do it in a neighbourhood, they do it in a place. If you can't do it in a place, you do it in a system. Now, if you take primary care in this model, it must operate at all of those levels. And if it does, then we can make changes, not just to the way that we drive outcomes for people, but in the viability and sustainability of general practice, which all international comparisons say is the cornerstone of our system. And I think that we've demonstrated over the last 5 years that you can do that. And we've seen definitely during the pandemic that where you have systems working with places and neighbourhoods, you can deliver better services, you can respond more quickly, and you can drive improvement. And I think that's what this act is about. This is what this bill is about. It's about setting a broader strategy through the partnership around housing, education, employment, green space, and health and care. And it's about creating a model where you can then implement the plan from that strategy so you make a difference to people's lives.
Rob, that's a wonderful answer. Thank you. In some ways, I think it comes draws a circle neatly back to one of Martin's early points about the need to fix fragmentation, but the question mark over whether this is the right route to that. I think you've just drawn quite a compelling picture of how it could be a route to fixing fragmentation.
Yeah.
What I'd like to do now is just kind of delve a little bit into some of the issues that have been raised in those answers. I think there's something about the loss of CCGs that we probably need to discuss. How much of a loss is that for general practice? And you mentioned money. I can see popping up in the Q&A. People are worried about, what does the loss of CCGs mean? I think we need to talk a bit more about primary care networks and their role in this. Are they mature enough? And I think we need to come back to the question, and Rob, you've just spoken about this, of really how does this go through to the patients and the people ultimately who we serve in the communities we work in. So if we talk first perhaps about primary care networks, and Farzana, it would be great to get your thoughts on this first. Manish Prasad has rightly pointed out this is a huge ask for PCNs. We're 2 years into a PCN contract that has seen a pandemic kind of run riot through it. Do you think PCNs are mature enough to cope with the demands that are going to be placed on them? And if not, what needs to be done to support them?
Thank you, Manish. Great question. The short answer is no, but I'll elaborate on that. Just as, Rob was saying, and Martin was saying, ICSs are in different places. PCNs are at different levels of maturity, aren't they? So we've got so many, over 1,300. So we've got loads of PCNs, different levels of maturity. And of course, let's not forget how well PCNs have done. Suddenly there was a pandemic and suddenly COVID vaccine came out of nowhere and PCNs had to deliver it. And we did, and primary care delivered 75% of the vaccines, which has been one of the most successful vaccine rollouts in the world. So let's not underestimate how much PCNs have done. But I'm increasingly finding that actually PCNs seem to be thought of as the go-to answer for everything. Your mother needs a new hat, the PCN will do it. We need to think about increasing workforce, the PCN will do it. We need to improve learning disabilities reviews across the patch, the PCN will do it. And I think we need to just remember that what are PCNs? They are just groups of general practices. We haven't magicked up and cloned more Robs or more GPs. They haven't come out of anywhere. I think the strength of the PCNs has been collaborative working in the more mature ones, not only within general practices, but with the partners, with our public health. And of course, the pandemic has really shown that how PCNs have worked with public health and very much so with acute trusts as well. I mean, certainly where I am, advice and guidance is working really well. The pandemic enabled us to have conversations with hospital doctors because we all wanted to achieve the same thing for the patient with a massive backlog. But the command and control, particularly in the bill, worries me because it almost, for me, Beck, sets a precedent of actually if our politicians can abolish something at the drop of a hat, leadership comes down to all levels. If that's the tone we're setting, then that ICS, which is a lot, 2 million is a lot bigger than a little 30,000 PCN. A clinical director is not a CEO. A PCN manager is not a CEO. We've got different skills. And I think that by design, it becomes a bit, let's tell the PCNs what to do. And I think it's going to be quite a tall ask to resist things that I think PCNs feel they can't do at this moment. And I'm certainly saying no a lot to a lot of things. And also really think about what is the purpose of a PCN? For me, the purpose of a PCN is to improve the health of our communities, our populations. And we know that quite well because we're working with that smaller population. It's not necessarily saving money. If that happens, that's great. And it's not necessarily getting your mum a hat because nobody else is going to be able to do it.
It's a really interesting tension, isn't it, Farzana? I worry that the more that PCNs become of the system, the less perhaps GPs and healthcare professionals working within them feel local ownership at neighbourhood level. Rob, I think you wanted to come in, and then Martin.
Yeah, I think so. So I think Fazana's hit the nail on the head with, the fact that PCNs have been magnificent over the last 18 months, and that's because real change happens in real work. So I think we can be obsessed with planning and preparing for something, but when we have to do something, we end up delivering. And where PCNs have been really effective is where people have seen that there's this is a joint piece of work between the PCN, some kind of voluntary sector infrastructure, which can bring together the voluntary sector around the primary care network and the neighbourhood, social care and the broader NHS. And this points to me to something philosophical, which is the PCN and the neighbourhood in that way is it's a manifestation of the system. And everything's really a manifestation of the system. If you're an individual and you've got lots of people supporting you, that's a manifestation of the system at that level. If you're a practice, you're a manifestation of the system. If you're a PCN, you're a manifestation of the system. We've got to get into this system thinking and away from hierarchical thinking. And that is countercultural, and it's counter to what's in the Act or the bill around what the former Secretary of State would like to see in there. I think the NHS piece of work that was done around what legislative changes we might want to see did not include those broad powers for the Secretary of State to do something if he or she was minded to. So I think when it comes to PCNs, we've got to recognise Martin's point: capacity for change and support must be made available, and that should be through some of the capacity freed up from CCGs.
Rob, can I just ask you on that point, because there is a worry that some GPs have articulated, which is, and it's very clearly set out in the design framework, that there isn't funding at the moment for PCNs to get that capacity and support. So they're going to have to get it from within the ICS, presumably from the Integrated Care Board. There is a worry being articulated that that's going to mean primary care kind of going cap in hand to a board on which it has relatively little power. Is that a kind of worry you would share or not?
Certainly a question that needs answering about what priority we putting into system development, organisational development, like we call it system development. And if we don't put priority and capacity into it, then we're going to fail. And it should be a priority for every system to put capacity and resources into supporting primary care, and then primary care's place in PCNs and the development of neighbourhoods. And as we delegate budgets and responsibilities to places, which replace CCGs, and they're different from CCGs because they're true partnerships, you would want to see the development of their place and their system with PCNs within it prioritised. And having GPs in the PCN, having GPs on the place-based arrangement, and having GP voices, representative voices, on the statutory body and in the partnership board should allow people to make that point.
Martin, can I bring you in here on representation on ICS boards? Quite a few people have been asking about it, and college clearly played a significant role in getting us there in the first place. What's your current view on how you see that working well and what needs to happen or to change?
Yeah, so could I first, Bets, could I just respond to your question about PCNs and CCGs, actually, because I agree entirely with Fazana that PCNs are in a very different place. Some of them quite mature, doing some really interesting work, some of them really not functioning at all. And if you were trying to design a better system, particularly a more integrated system, you probably wouldn't give a big responsibility to an organisation that's only 2 years old. So, ideally what you'd like to do is delay these reforms for 10 years, allow PCNs to mature. Okay, naive, isn't it? But that's ideally what you'd want to do. In principle, as a college, we were in favour of abolishing CCGs, because for the simple reason that we didn't want the organisational complexity of many organisations kind of within a larger organisation. We've got too many layers of organisations already. The problem, though, is that CCGs are relatively mature organisations, and some people think they've done a great job, some people think they've done a less good job. But the reality is that they've been really well resourced because they've used a small proportion of their overall commissioning budget to provide a management infrastructure for primary care. And that's been a really important part of their success. And their ability to wield influence within a local community is a consequence of having that big commissioning budget. So the question in my mind is how is general practice going to wield that influence when you've got very small, 1,250, whatever it is, very small, immature PCNs, and that is a massive challenge. And one of the big asks for us is, if you're going to take away the management infrastructure for CCGs, then for heaven's sake, at least put it into PCNs and make sure that they're adequately funded. Because there's an awful lot more that PCNs could do if they had the proper infrastructure and were able to be funded. Now, what's the future of PCNs? I don't know. Are they likely to merge? Probably. Who knows? I don't know. But I think getting that right is really fundamentally important. In terms of the GP voice, as I described in my introduction, having one person, one GP on the board has been quite a controversial bit of lobbying for us in many ways, because, Royal College of GPs, of course, that's what we'd asked for. But then you've got patients who want to place, you've got nurses who want to place, you've got a whole range of different allied health professionals who want to place as well. Our argument has been, general practice is important. Pragmatically, GPs kind of wield quite a lot of power and influence, so it makes sense to have them there. But we're more than aware that one GP, however they get onto that board, is not going to be enough. And if that GP, I don't know how that GP is going to be appointed. That's a kind of a big question to me. Are they elected by the membership? In which case, what does that mean? Do we want them to be from any background? Do we want them to be from an LMC background? Do we want them to be from a college background? So many questions that need to be asked there. But having that voice, and not just that voice, actually, it's one minimum. Having primary care voices across that board is going to be really important to the success of making it happening, because they're the people who are going to get the strategy right and get the funding flows right.
Yeah.
And then what you really need is the worker primary care representation, general practice representation lower down in the system, particularly at place level.
So can I just come in there just to say that, I think we need to have a sense of fairness and equity, and people recognise they can see themselves in the decision making. And having strong primary care voices on the board of the statutory body is a really good thing. We can't confuse that with clinical leadership and decision making in the system. So if we really believe that we're moving to a networked model of leadership here, with distributed leadership and clinical and professional leadership being context specific, then you need people who are leaders right across the system who you can call on to address specific problems. So the GP leaders that I call on, for example, to help us with definitions of carers, so we can be consistent when we're offering vaccinations, and then making sure everybody's happy and delivering against that, are different from the ones who are doing the work on stroke care and rehabilitation, and that's fine. But what we do have is a very thriving, multi-professional clinical leadership cadre, which includes primary care, which can, through a forum, dock into decision making. And that needs to happen at primary care network level, it needs to happen at place level, and it needs to happen at the board. And I would want us always to keep coming back to this: representation is important, but it won't do anything in isolation. It will only work, as you say, Martin. How are you choosing who these people are? What are they docking into? And how are you changing things so that people genuinely feel like they have a say in the way that services are delivered?
Rob, can I stay on this theme of representation and ask you about patients and service users? Althea Bart has asked it. It's our most popular question at the moment. Somebody else in pre-questions had said they felt that patient participation groups were becoming less important in the context of PCNs. That's clearly an enormous loss. And a lot of people very worried about where the patient's voice is in this. I wondered whether you could share a little bit about how you're managing that at the moment.
Well, the first principle is we always have the patient or person in the room with us when we make decisions. So our current governance, we've got a partnership board, which is politically chaired and politically led. We've got an executive, we have place-based arrangements. Every single one of them has lay membership on it. And Health Watch, all the Health Watches collectively sit on it, and the VCSE, and we've given them carte blanche to be our Jiminy Cricket on patient voice. That's backed by an ethos of co-production, genuine co-production with people at all levels. And what we try and do is recognise and harness patient participation groups in general practice, the membership of foundation trusts, the youth fora and citizen panels in councils, and bring all of that to the party. So I think there's a kind of philosophical point here. There's a point about harnessing what you've already got, and then there's something about connecting that into the governance. So our, because it's a minimum of a primary care lead, a provider lead, and a local government lead, we will have citizen voice on our statutory body, because it's important that we do.
Martin.
Fazana, I don't want to jump in if you're about to, are you about to jump in?
I can wait. Let me let you, and then I'm going to jump in after you.
You're kind, thank you. We need to think radically about this, because with a few exceptions, I think Rob's area is one of them. The NHS is really bad at patient involvement, but actually local government is really good. I mean, really good. And if this is proper integration, then why don't we use the resources that are available, the community support groups, the community engagement groups that exist through local government? And one of the things that I've learned, I've worked as a GP in 3 different parts of the country in my career. First of all in Devon, then in inner city Manchester, and now in East London. And it's only in East London that I've seen really good partnerships between the NHS and the boroughs. And those partnerships have really opened my eyes to the kind of work that can be done when you have a democratic voice, which we don't have in the NHS, of course, for the public. So maybe let's be really radical about this. Let's go for the Swedish model. Let's get the NHS run by local government. No, did I just say that? Maybe, but why not? Why not? It would really absolutely change the nature of what we do in so many different ways. A democratically accountable health service, that would really bring a strong patient voice.
Fazana, what are your thoughts?
So I was listening with interest to what Rob was saying about representation, and I was just reflecting on the difference between representation as a whole. I'm a GP, so because I've got a GP badge, I need to be on this board, versus that purposeful leadership of there's a shared purpose and we want to sort this, and somebody will sort this. So we need to remember that not all clinical directors are GPs, the majority are GPs, but we have some up to, I think, 19 in the country nurse CDs, we've got pharmacy CDs, we've got a paramedic CD. If we look at some of the great learnings we've had from COVID, we can see that when we're thinking about our patient voices, Newham is just one example of many areas where 100 COVID champions just emerged. These are people from the community who are not getting paid, who wanted to make a difference to help our community get COVID vaccine. They came in their own time, they trained up in what are frequently asked questions, and they helped their community, our community, to come forward for COVID vaccine and answer any questions. That was so powerful. PCNs, some more mature PCNs in the country, some in Milton Keynes, many of you will know Teo, have patients on their board, on their PCN board, but that's still variable. Not all areas have that. But I do think we need to, of course we need representation, but I do think we need to go wider than representation and learn from, for example, these COVID champions, and think about what we can learn from each other. I mean, I'm intrigued by Martin's, model, local authority Swedish model, because actually, I mean, a very quick example is one of the projects we're doing as a PCN ourselves around population health is to reduce knife crime, because that's a local issue that we have in Newham. Lots of young people dying from knife crime. And I was on a call today with some schools who head teachers who could give me so much information that I would never know. We've got our young people's forum who are part of that, and I just think that sometimes as a GP, I feel I ought to know and I should know because I'm the profession. I think we just maybe need to think about all the other assets we have if we're really going to work collaboratively, and our communities are a rich form of that asset.
Can I just say,
Please do.
Fazan, I think that's beautifully put and entirely right. If we look at Hollywood in a pandemic, what happens? Society breaks down, everyone kills each other. What have we seen? We've seen an outbreak of altruism. Societies come together. People have marshaled themselves around shielded folks, people with learning disability, the vulnerable, and they've done that before we've got there in many ways. So I think we've proven over the last 18 months, if ever we were in doubt, that there are assets in our communities that we could use if we only chose to see them.
I think it's something that is coming quite strongly. Sorry, Martin, I will come to you just a sec. I just want to bring in another kind of theme from the Q&A that is coming up, which is a lot of people, Pretty being one of them, raising concerns about the workforce at the moment. And I think there will be an argument that says, well, okay, everything you're saying makes perfect sense and is what I would aspire to. And perhaps if I did have 42 clones of Rob, I might have a better chance of it. But actually, at the moment, half of my practice staff are off self-isolating and we're absolutely knackered. And how do we have the headroom to do this well? Because like it or not, this is happening. The white paper framework was by April 2022. And so folk in the chat just reflecting that challenge, I think. Martin, I don't know whether you have thoughts about, in practice, what does this reform being implemented now mean for general practice in the context that we find ourselves in at the moment?
Yeah, I have lots of thoughts and not many answers, I'm afraid, because the challenge is absolutely right. When a workforce is on its knees, how do you encourage them to engage in an initiative that really does need quite a high level of engagement, not from everybody, but from a reasonable number of people, and it's really difficult. And yeah, I don't need to repeat all the stats around rising numbers of consultations, rising complexity of consultations, growing number of things that we're asked to do, changing practice, particularly around long COVID. The stress that general practice is under is truly phenomenal. And we've been pushing very hard for extra GPs and have had great success in terms of the recruitment, growing number of training places and over 100% fill rate, which is great. No success whatsoever with retention. More and more people working part-time and leaving the workforce early. And our most recent survey of our members suggested 34% of the workforce is going to retire in the next 5 years. That's a hell of a lot of GPs going in one go. So we do have a massive challenge, and the implications of that are obvious challenges for the mental health and stress levels of the workforce. Again, some pretty frightening stats. 60% of respondents to a recent survey said that their mental health had deteriorated significantly in the last year. And 42% said that at least once a week, they woke up thinking, I can't do this job anymore. Now that's a terrifying position to put a group of health professionals into. So that's the environment in which we're trying to change. Now, that's why the case for change is so important, because actually the integration of care, the efficiencies that come with it, the satisfaction that comes from working in a health system that works rather than one that's fragmented and doesn't work, those are all actually parts of the solution to the workforce crisis. So, I can intellectualize and I can conceptualize the relationship between what we need to do and what we're trying to do, and the way in which integrated care is the answer to many of our problems. But I can also absolutely feel the pain of the individuals who say, but I don't know where to start because I haven't got any breathing space. My head's down and I'm just about in survival mode, but only just.
It's hard, isn't it? And I think it comes off the back of PCNs, which certainly to me, in January 2019 felt like an enormous ask of general practice then. And I think there will be people, as Fazana was talking about earlier, saying, well, look, PCNs have become the bucket that everything is being thrown into. And now you're putting more and more on us, and that's a challenge. And Leslie Hughes has just asked about the need for education to support primary care to adopt its new role in the system. Something I think that's been really exciting about PCNs is that they've enabled lots of GPs who hadn't previously held leadership roles to step into them. but are they adequately supported? And Rob, Fazana, I know you have thoughts. We've got just a couple of minutes before I want to do a kind of round robin of final thoughts, but interested to get your perspective, Rob, first of all, on what you as an ICS lead view your role as being to support primary care to step into the role that will be expected of it.
So firstly, just to make sure, you got to connect more of the system to itself, I think. And there's a famous Martin Marshall paper about general practices being clannish because they're very dynamic but very focused on the practice. And what we need to do is change that and recognise that practices and PCNs not being asked to do things on their own. There's an infrastructure here through the system that says, community mental health transformation brings with it capacity to resolve mental health issues. Social prescribing link workers and support for the third sector and infrastructure for the third sector brings, support and capacity to help with social problems. That's 20% and 50% of some of the issues that are coming through the door every day. And if we can marshal that together over time and give people the leadership support that they need, then we could be successful. The one thing I would add is, this isn't going to change tomorrow. And the good thing about primary care is people stick around. The good thing about local government is people stick around. And what we're looking at here is a series of changes which will take time, and that's okay. We just need to give people time.
Fazana, I know you have a slightly different relationship with an ICS in North East London than perhaps Rob has leading his. And I just wonder what your perspective as a PCN clinical director is at the moment about the support you feel that you need.
So I think the stats speak for themselves, Bex. 1 in 5 CDs left their role after the first year. So I think that speaks for itself. Some of us have been GPs 20 years and a bit long in the tooth with experience. It's been great to see, younger CDs come forward, and it's been really tragic to see them not have that support and be leaving. So I think there's a lot more to do. I'm reminded of, the too busy question. We are, it's really busy in general practice at the moment for everybody. And that's without all the noise that's going on about general practice hasn't been open and all that extra pressure that's been put and the narrative about. And I'm reminded of that slide that many people have seen where the cavemen are trying to push their boulders along and someone comes along with a wheel and they say, no, thanks, I'm too busy. And I'm just reminded of that because the reason I think this is so important is because we haven't got the headspace at the moment. So a very personal example, in 18 years of running my current practice, one of my salary doctors just gave birth to her baby girl yesterday. For the first time ever, I haven't managed to get even a locum to cover her 6 sessions. I'm let alone a salaried. Agencies are saying to me, we just can't find the doctors. So, we really are that busy trying to keep running a service. So I fully get it. But what I would say is, as Rob says, be bold to take that time. We've got 26,000 ARSS roles. They're not cooked yet. They're not ready. They themselves need a lot of training. We need to know how to work with a link worker. When our first link worker came, we all looked at him like he was an alien because we didn't quite know what he did. So we wondered who was training who. But we're all learning. And as Martin said, we wouldn't necessarily think of an organisation that's only 2 years old and then stick another load of change on that to a whole load of GPs where there aren't enough of them and they're in the middle of a pandemic. But that is where we are. And I think we just need to be bold to say we're not going to change the world overnight, but actually we are taking baby steps. Those ARSS roles are here. We are going to get support, like Rob said. And with all the sadnesses in the pandemic, I can say I've never seen a time where consultants have picked up the phone. In January with the second wave, I had a casualty consultant call me up saying, "Can I speak to her?" Very meekly, and I said, "Yeah, what is it?" So this person's not ill enough to admit with COVID, and could you, and I was waiting and I thought they wanted me to something brilliant, and they said, "Could you write up a few prescriptions for this patient?" I was like, yeah. And it made me think that actually, they're as afraid of us. This is just about talking. This is about people just on the front line thinking, how are we going to sort the 5 million backlog out? Actually, it's going to be people talking to each other. It's not going to be massive organizational changes. It's going to be people talking to each other about, let's see, with our community, with our patients, does this person need a hip replacement? What do you think? Is there something else? And that's been shown in COVID. So we could do more of that. So I think we just need to hold our nerve. We are going to be okay. We need to hold our nerve.
I always find it very inspiring chatting with you, Fazana. Thank you. We've kind of raced through 55 minutes of our hour. And so I'm going to put a little bit of pressure on you all, if that's okay, with just a kind of final round of a question. We all know that these reforms are kind of far from a done deal. There's been wrangling over them in Parliament this week. There will be more changes through the parliamentary process, I'm sure. But in addition to that, there's going to be a load of guidance that NHS England will have to develop alongside them. And so the question that I would just put to you for a kind of 1 minute response each, and I know this is difficult, my apologies, is what one thing would you want to put in that guidance to strengthen the general practice of the future? So what would your ask of the kind of NHS England team be? Rob, I'm going to come to you first, if that's okay.
I would make sure that the subsidiarity principle was the first principle in everything that we did. So that the person and then the practice and then the PCN and then the place and then the system, we saw it that way around. Because fundamentally, I believe that these reforms could be about a new model of family medicine, which means the mental, physical and social needs of people.
It's a wonderfully upbeat answer. Thank you. Fazana, your thoughts?
I think give us shared incentives. Let's get away from the tribalism of organizations and professions and representation of an organization. Give us a shared incentive to reach that shared purpose, and let's involve our communities. It is no accident that in the Marmot report, if you are a woman in a socially, financially deprived area, you die 10 years younger today than you did 10 years ago. That is shocking, and that is no accident, and that needs to change. And we are here for the people we serve, not because we're GPs or because we're hospital consultants or because we're nurses. So if we keep that in mind and have the shared incentives, if we're really going to collaborate, it's more than a duty to collaborate, which says on a piece of paper. We want to collaborate because it's the right and humane thing to do. So we want all our policies to be starting with that principle and give us the shared incentives rather than everybody having little pots, whether that be money or resource. And I mean in workforce as well. If one area has got a deficit of workforce, why don't we get another area to do that? The hospitals have shown that brilliantly with deploying people to their ICUs. Why don't we do that as a system?
Thank you. Martin?
Bex, I'm going to be a proper contrary GP and say your question's wrong, actually. So I don't really mind too much what happens to legislation, because that's not what's going to make a really big difference to patient care. So if you look at the history of the evolution of general practice over decades, you'll see some trends which I think are largely positive. So trends towards providing a bit more scale, which provides infrastructure for general practice to allow it to do things professionally, like using data effectively. Trends towards multidisciplinarity, which is really exciting because you can utilize different skills within the team and you can allow the GP to focus on where they add greatest value. And trends towards increasing interest in public health, Fazana's agenda, health inequality, social determinants of health, use of social interventions, trends towards better integration and trends towards better use of technology. All of those are trends which have been happening for decades, are going to continue. Our job as leaders is just to speed up the pace of those trends, it seems to me. And legislation can sometimes speed them up a little bit, but sometimes slow them down a little bit, certainly for the first 2 years of introduction. So let's not get, with great respect to policy wonks like you and me, Bex, let's not get too obsessed with the legislation. This is about having a vision of where general practice is going and really enabling that and leading that with enthusiasm, because general practice is so important.
Martin, that is a wonderful note to finish a webinar on the meaning of these reforms for general practice. Thank you so much for broadening it out. To close, I want to thank you all. You've been an absolutely incredible panel, and I'm really, really grateful to you for giving up your time, your wisdom this evening. I'd also like to thank the Health Foundation team behind the scenes this evening, in particular Fran, Nick and Maeve, for supporting the webinar. And thank you to the hundreds of you who have joined us on this webinar tonight for contributing your questions and thoughts. I really hope this has been what you hoped it would be. We'll get a recording of the webinar up on our website as soon as we can. The slides will be there too, and we'll be closely monitoring and commenting on the bill as it works its way through Parliament. So keep your eyes out on our website for future events and publications. Have a great evening. Stay safe. Good night.